Waiting is messy.
सेल्समैन है
फिलहाल कुछ बोल के देख वॉइस आएगी
जो सबको अलाउ नहीं कराना अभी
नहीं तो एटलीस्ट इससे आवाज आना चाहिए यूट्यूब में मेरे वीडियो so there is a backlog
Good morning. Good morning,
Good morning,
Sanjay.
doctor. How are you?
I am fine.
Very nice. Good to see you.
Nice.
So whenever you say start, we can start.
No. Yeah.
Setup is fine, sir. Even in YouTube.
What you say? Live on YouTube, my goodness. Whenever you say start, I'll start.
This is only for our people, no?
If you want to watch the movie, it's not on.
This is only for Sanjay.
Good morning, everybody. What we'll do in the next half an hour, 40 minutes, is to look at how do you approach this topic of adjuvant and neoadjuvant therapy in pancreatic cancer. And what I'll do is to mainly focus upon operable and borderline operable pancreatic cancer. I think locally advanced pancreatic cancer is something that we have discussed many times. This is a talk I did a few months ago for the gastroenterologist. So if you have listened to that talk earlier, doesn't matter. This will be a quick revision for you. And I have also added some data from the latest ASCO conference. If you haven't listened it earlier, great. All this will be hopefully new for you. Okay. So this slide is not meant to be read. So this slide is meant to tell you that there are so many classifications of what resectable, borderline resectable, and locally advanced pancreatic cancer is. Depends upon whether you're looking at the MD Anderson or the surgical oncology group or the NCCN and so on and so forth. Depending on what criteria you're following, your definition might change a little bit. And so the same thing happens when you're reading a trial of borderline pancreatic cancer or locally advanced pancreatic cancer. Each one of these trials may have followed a different criteria to define their patients who need to be included or excluded from their study. Now, since I am a physician and I'm expecting that a significant proportion of people who are listening to this talk are not surgeons, it's important to understand a little bit of anatomy to know what is borderline operable, and locally advanced. Now, that is the pancreas, that's very clear, that is the bowel. So these are the area where we need to concentrate upon. These are the veins, that's the artery because it's red and blue, and that's very, very obvious. So the two most important vessels are the superior mesenteric artery and the superior mesenteric vein. Of course, as you go up, you have the common hepatic artery and the celiac trunk. Now, the other important point that one has to make or understand is that whenever you're talking about resectable, borderline resectable, and locally advanced, it's not only a reflection of anatomy and the way the disease has increased, it's also a very, very important reflection of biology. Those which are locally advanced or unresectable at the time of diagnosis also have bad biology, and that also is reflected as part of their outcomes. Now here, that's the pancreas, that is the tumor. We said the superior mesenteric vein and the superior mesenteric artery, which are the structures that are illustrated here, are totally away from this mass, right? So that is typically something that you will refer to as resectable. And on this picture, this is resectable. This is a mass that is sitting in the head and partly in the uncinate process. It's far away from the vein and the artery here, so that's clearly resectable pancreatic cancer. When it comes to borderline resectable and locally advanced, you now start seeing that the mass is either abutting or involving a little more of these vessels, and that is illustrated here. you see that the vein is significantly involved here. It's probably just abutting the artery here. So that's borderline resectable. They will talk about less than 90, less than 180, and so on and so forth. That's not something that we will break our heads about today. So that's borderline resectable pancreatic cancer. Now, when it comes to locally advanced, you almost don't see these vessels, okay? Now, even in the locally advanced, you have a category which can be converted to an operable pancreatic cancer with some radiotherapy, chemotherapy, and so on. You have another which is referred to as the type B locally advanced, where in spite of all this neoadjuvant therapy, you will never ever be able to convert that into an operable pancreatic cancer. So remember that you need to put your patient into one of these baskets when you're talking about neoadjuvant therapy or reading a paper which is talking about neoadjuvant therapy. What sort of patients went in? What was the criteria used to say this is resectable, borderline resectable, and so on and so forth? So I hope this gives you some idea of what the anatomy and the classification is. Now, this is another simplification. So you start from resectable at the bottom and can get to unresectable depending upon which one of these criteria are there. No arterial venous involvement, obviously resectable. While if it's distant metastasis, it's obviously unresectable, and you have all of this which falls in between these two categories. So remember to look at this whenever you are looking at your next scan of a patient with pancreatic cancer. So let's get into the important things. The first question is, who goes for surgery upfront? Now, this is a condensation of the ASCO, the NCCN, and the ESMO guidelines that were published a year ago or a couple of years ago, and so on and so forth, depending on when they were updated last. So who goes for surgery? Group number one is no clinical evidence of metastasis. Now, should you do a PET scan for all of these patients? That's a controversy we will not get into today. Selectively, the answer is yes. Good performance status, acceptable comorbidities, which means you're talking of medically operable. Tumor vasculature interface is free. We have already spoken about it. CA19-9 levels, now that's a very subjective issue. Beyond what CA19-9 should you certainly take your patient for some neoadjuvant therapy, even if they look operable medically and technically based on a scan. Some people think the value should be less than 500 for you to take them to the operating table straight. Now, is there very nice, high quality evidence to support this number? The answer is no. But that's what we've come to accept based on whatever flimsy evidence is available. Now, it makes sense to draw a line at some point, because if you are having a very high tumor marker value, there is a higher chance that you've got somebody with systemic disease and you don't want to take them up to the theater, open them up and find that there is peritoneal metastasis, which was not made out on your conventional scan that you did. So all of these straight away go on to the operating room. The rest go for preoperative therapy. Now, once you do surgery, who are the patients who warrant adjuvant chemotherapy? We'll come to radiotherapy a little later. What is its role? Who goes for chemotherapy? All resected patients. Now, I'm stressing that again, all resected patients. This includes T1, because all of us have this impression that if you've got a T1, let's say a 1 centimeter tumor, the biology and the outcome is going to be super, and you don't have to do anything. Now, remember that even for a T1, the chance of recurrence is 50%, which is very high. And if you say that I've undergone a surgery that may come with huge morbidity, and I'm going to get a 50% risk of recurrence, obviously you want to get that result better by adding some therapy later. So everybody goes in for adjuvant therapy as long as they're medically fit to undergo this. What is the exception? As in our adenocarcinoma, because the prognosis of an acinar adenocarcinoma is better than a ductal adenocarcinoma of the pancreas. Acinar adenocarcinomas T1 don't require therapy because their risk of recurrence is lower. How low is it? The risk of recurrence is between 20 and 25%. Still, we would not consider that as low, but it's certainly lower than what you have with ductal adenocarcinoma of the pancreas. When do you need to start them? Ideally, within 8 weeks of surgery. There are some analysis which have been done on patients before and after 12 weeks. There is a compromise as you go later, but please remember that even when patients were given adjuvant therapy after 12 weeks, which is 3 months from the time of surgery, those patients had outcomes that were better than patients who didn't have any adjuvant chemotherapy at all. Now, this has its own biases in terms of selection of patients. This is retrospective. Nobody would prospectively look at this particular issue. So some chemotherapy, certainly at some point in time, looks to be what we should do for our patients. How long? 6 months. This includes neoadjuvant therapy if any has been done. Should you restage all your patients before starting adjuvant therapy? The answer is ideally yes. What imaging? A CT contrast of the abdomen and a CA19-9, and very soon you will understand the relevance of why this should be done. Now, these are some of the studies that were done in patients with pancreatic cancer who had surgery and then went on to have adjuvant therapy. Just look through these numbers. The median overall survival in the earlier era is anywhere between 15 to 20 months, right? So the average survival is less than 2 years. The 5-year survival is around 20%. So 1 in 5 patients who has had surgery and adjuvant therapy will reach the 5-year mark. So 20% 5-year survivals, average survival of about 15 to 20 months. Keep these two numbers in mind, because the numbers that I'm going to show as we go on with the newer studies and trials may be a little better with the newer chemotherapy regimens and so on and so forth. Now, we started with just 5-FU leucovorin, then went on to compare gemcitabine and 5-FU leucovorin, and then went on to say that 2 drugs are better than 1 drug. So gemcitabine versus gemcitabine and capecitabine. The median survival for gemcitabine was 16 months, which is typically what we would expect, but that increased to about 28 months with a combination of gemcitabine and capecitabine. So we made some improvement, some increments in the overall survival for these patients. But what is it that we do today? Ideally, what we do is a regimen, a very intensive regimen called FOLFIRINOX. Now, what we use today is a modified FOLFIRINOX. It's not the FOLFIRINOX that we all started with, because that's a little too toxic. Patients who were operable had surgery and then were randomized to FOLFIRINOX versus gemcitabine for 6 months. Now, remember, I made the point regarding CA19-9 and a CT scan after surgery. In many of these studies, including the SPAC, this was not included before they were randomized. So there were patients who had a high CA19-9, telling you that those are patients who actually had metastasis which was not picked up by scans or at surgery. They belong to a poorer prognosis group. They did not have a CT scan before surgery to make sure that there was nothing inside, and we were starting with a clean slate. So inherently, the Prodigy study had a better group of patients compared to what the earlier studies had started with. So this is very, very important to again look for and remember whenever you're reading a trial with patients who have had surgery for pancreatic cancer. We'll come to the R0, R1 resection a little later. That's also very, very important to understand. Median overall survival, a brilliant 54 months. Remember, gemcitabine, capecitabine, we spoke about 28 months. We have doubled that overall survival. I would partly attribute that to the way patients were chosen, and partly to the regimen that was used, which was much better than what we earlier had. Remember, again, always look at the comparator arms in any randomized study. What's the survival in the comparator arm? Remember, the comparator arm was gemcitabine 16 months in the earlier study, which went up to 35 months. Again, the comparator also has had a doubling of the overall survival. Now, what does this reflect? One, a good group of patients. It also tells you that we have had better treatments for metastatic disease over time, and at least some of these patients would have had some kind of a life-prolonging treatment which improved their survival from what you expect, which is 16 months, to where you got to, which was 35 months. So again, remember that your performance is only as good or better than your comparator. You have a poor comparator who had poor post-progression therapies, your performance always looks better. But if your performance had to look, has to be put on the same pedestal, then you have to make sure that your comparator also had all the equally deserving therapies post-progression. So this has to again be kept in mind. The 3-year overall survivals, which usually are around 30%, right, went up to 40-45% here versus 63.4, a hazard ratio of 0.64. So I think very healthy data, practice changing, and has been adopted all around the world for patients who are fit for FOLFIRINOX. Now, why is it that I'm making that point? Because look at it, in a clinical trial which is well controlled in terms of patients who enter, only 66% will complete. It's not too high on the gemcitabine, please remember, it's 79%. It's not 95 or 100% as you would expect it to be, because all of us think gemcitabine is a song, right? So patients with pancreatic cancer are not patients who can take very intensive therapies. Very much doable, but you have to carefully do this on patients, because even in a controlled situation on a trial, nearly 40% don't complete all the planned therapy. So when you choose your patients, this is important to keep in mind. Now remember, I made a point regarding margins. Now, pancreatic cancer, very interestingly, is one area where the margin positivity rate is 40% on an average. Now, try to recollect any other anatomic site in the body where this would be acceptable if your surgeon had 40% margin positivity rate, let's say for a colon cancer or a breast cancer, that would be criminal, right? In pancreatic cancer, the other thing you have to look for in all these studies is what was the definition of R1? Because if you were Japanese, the definition is different. If you were Caucasian, the definition is different, okay? And depending on the definition, the margin positivity rates might vary. For example, in the Prodigy, if I'm not mistaken, the margin positivity rate was only 20%. While in some of the European studies, you will see margin positivity rate of anywhere between 40 to 50%, which typically all of us would say is unacceptable in a curative situation, but that's the reality, because this is how you can define margin positivity. Less than 1 millimeter where cells are still there, or cells at the margin. So depending on what your definition is, your margin positivity rate might increase or decrease. Again, please note this whenever you're reading a study. Look at this, in some of these studies, you don't get any benefit if you had a margin that was microscopically positive or R1. Now, 2 important studies, the CONCO. The CONCO is where you were looking at gemcitabine versus, I'm sorry, it's not the CONCO, we are looking at the SPAC, where GemCap was compared to gemcitabine, the study where we showed 28 months of overall survival. If you had a margin that was positive, and this is how it was defined, you don't get any benefit there at all. So all the benefit for GemCap was actually driven by patients who had a margin negative resection. Similarly, look at what happens in the Prodigy study. You had patients who didn't have margin positivity, or only 20% who had, but there was benefit even in this 20%, right? A 0.52 hazard ratio for the whole study was 0.64. So depending on what your margin positivity is, you may also decide to choose your adjuvant therapy based on that. So for me, based on at least randomized evidence, there are two regimens that you can choose if somebody has a margin positivity, ideally FOLFIRINOX. If not, gemcitabine should be good enough because gemcitabine does not seem to be offering a benefit if you have a margin that's positive. So again, an important point that one has to look for in the pathology report. Now, if you go and audit your pathology report and see that 100% of your surgeries are margin negative, that should raise a flag, because that means either your definition of margin positivity is not appropriate, or you have a pathologist and a surgeon who are working hand in glove. So please remember that always. So what's the practical approach for a patient who's had surgery with curative intent? Very fit, FOLFIRINOX. Less fit, margin negative, gemcitabine, capecitabine. Less fit, margin positive, or less fit, gemcitabine. If your surgery was so good, within inverted commas, and your patient never got back to see the medical oncologist, which you will call as less fit, it's perfectly all right not to give them anything at all, because if your patient's performance status is poor and you started this patient on chemotherapy, you don't want it to cause a detriment at all. What is the role of adjuvant therapy? Again, like in many other anatomic sites, it's a huge Atlantic divide. If you talk to somebody from Europe, they will say it's criminal to do radiotherapy because there is absolutely no evidence. But if you went to North America, radiotherapy after surgery is nearly routine. There's no high quality evidence, but all their evidence is from the SEER data and the Mayo Clinic series, where they could show that CT-RT improved survival. So there are people who think that if you had an R1 resection, or if your lymph nodes were positive, there may be some benefits to addition of radiotherapy if your chemotherapy was gemcitabine. We don't know the same if your chemotherapy is FOLFIRINOX. So if you've got somebody who's taking gemcitabine, R1 or nodes that are positive, you may consider them for radiotherapy, not that that's high quality evidence. So summary for adjuvant therapy: do all patients need adjuvant chemotherapy? Yes. Which regimen gives the best survivals? FOLFIRINOX. Is there a role for other regimens? Yes. Gemcitabine S1, we haven't looked at it. Cross comparison of Japanese S1 studies to FOLFIRINOX shows that the outcome is absolutely the same whether you use S1 or FOLFIRINOX. If we have time for discussion, we will probably talk about this. How long? 6 months. What's the ideal time to start? 6 or 8 weeks. Who gets adjuvant radiotherapy? None, except in North America. If you decide to do radiotherapy, when is that done? It's done after chemotherapy, right? So we leave patients who have had resection, and then we move on to this slightly gray area, which is referred to as borderline resectable. Again, I don't want to go into the definition of this again now, because we said, depending on the clinical trial and where you're working, the entry criteria might be different. Now, why is it starting to make more sense to do neoadjuvant therapies? One, across the board, wherever you are, whether it's Europe, whether it's North America or the Far East, when you open up somebody upfront for pancreatic cancer, 1 out of 4 patients will be inoperable either because of local extent of disease, which was underestimated on your pancreas protocol grade CT scans, or you had peritoneal metastasis. So 1 in 4 will be inoperable. That means you unnecessarily open this. There's a very high incidence of margin positivity. We already spoke about it, and that will depend upon the definition of margin positivity. Again, like any other anatomic subsite, whether it's lung and many subsites in the GI tract, half of all patients don't get adjuvant therapy, which is life prolonging, right? You don't want to deny something that's life prolonging, especially in a disease which has dismal outlook like pancreatic cancer, even for stage 1 patients. So considering all of these points, the question that we are asking is, should all patients be subjected to neoadjuvant therapy because you might be able to bring down the incidence of inoperability? It may become 1 in 5 or 1 in 6. You may get more negative margins, and you may ultimately be delivering more chemotherapy, or rather chemotherapy, to more patients and potentially make them live longer. Now, this is a table that gives you lots of data on neoadjuvant therapy, but the one I have highlighted is a clean study from the Japanese group, which was done on patients who had operable pancreatic cancer. This is not borderline operable. And they could show that if you did neoadjuvant therapy, your overall survival was better. 36 months versus 26 months. Now, that's a huge increment when it comes to operable pancreatic cancer. They used their long-time, all-time favorite gem and S1 surgery plus adjuvant versus adjuvant S1 only. So it was not clean in a way. It was not clean because they didn't just look at S1 before or S1 after. They looked at gemcitabine plus S1. So did the neoadjuvant therapy do the trick? Or did gemcitabine do the trick? Or was it a combination of these two? We don't know. So in a way, it's clean, but a little bit of dirt there because you didn't look at that question in a simple, straightforward fashion. Now, this is the Priopan study again from Amsterdam, which looked at this concept of neoadjuvant therapy. What did it do? It randomized patients with operable and borderline operable, that's resectable and borderline resectable pancreatic ductal adenocarcinoma, 244 patients. Surgery followed by standard for them, which is gemcitabine 6 cycles. Remember, this was at a time when FOLFIRINOX was not standard. Randomized to gemcitabine radiotherapy, some more gemcitabine, and then surgery, followed by 4 cycles of gemcitabine. Again, trying to ask 2 questions. Is radiotherapy beneficial? Is neoadjuvant therapy better than adjuvant therapy? This is something like total neoadjuvant therapy that you do for patients with rectal cancer. That's where we are heading towards in pancreatic cancer also. First question we started with, is the resection, R0 resection rate better? Looks like it. The R0 resection rate on the immediate surgery arm was 30% versus 60%, so a doubling. So at least one of the intents or endpoints or objectives were reached. Now, when you look at the intent to treat population, remember, intent to treat is everybody who was randomized. So Krishna Mohan must have beautifully explained to you what an intent to treat analysis is and why you should do that last week. So if you look at the intent to treat analysis, there was a trend towards improved overall survival, but the p-value was not significant. So essentially a negative study for the intent to treat. So whenever we fail, what do? We go and torture the data because you want to find out some success in your failure. And when they did that, they saw that if you underwent resection, now why are they looking at it? As I'll show you a little later, when you look at patients who underwent any form of neoadjuvant therapy, 30 to 40% don't end up having surgery for various reasons. We'll come to that also a little later. So if you end up in the operating room, have successful surgery, then your overall survival seems to be better. What does this prove? It proves that there is a benefit to adjuvant therapy. There is a benefit to chemotherapy plus minus radiotherapy. It does not clearly prove the point that this should be given as neoadjuvant. Now, if you divide this into borderline resectable and resectable, this is the Kaplan-Meier for borderline resectable. This is overall survival. This is disease-free survival. For patients with borderline resectable, there seems to be a benefit in terms of overall survival and disease-free survival. Okay, so this is important, but this is an unplanned subset analysis. So we will always call this as hypothesis generating, not conclusive. This is for patients who had resectable disease. For patients with resectable disease, if you did neoadjuvant therapy, it didn't seem to benefit in terms of overall survival or disease-free survival. Now, whenever you look at a study, again, there are so many other learnings, not just what you get in the abstract or the result. It's very important to understand what is the compliance of pre-op treatment and adjuvant treatment. Again, look at what happens. If you do surgery straight away, only half of your patients get to adjuvant therapy. More patients get systemic therapy plus minus radiotherapy in the pre-op. So one objective again achieved. We showed you margin negativity at surgery. Again, it was achieved by delivering preoperative therapy. Interestingly, though there was chemotherapy that was delivered, there was no difference in the metastasis at surgery. Number of patients who had locally advanced pancreatic cancer at surgery because your assessment based on radiology was erroneous. 5% because some of them would have been downstaged versus 12%. Inoperability at surgery, bang on, 1 in 4, right? So this is just consistent data for all trials with pancreatic cancer who went in for surgery upfront. 1 in 4 will be inoperable. Very important number. Remember, I said 30% don't end up in the operating room at all because about 14% at least on the pre-op study ended up progressing. Now we are happy that we didn't take them to the operating room. We didn't put a knife on them because this would have been a failure that was attributed to the surgeon, right? Not necessarily to the disease biology, and we don't want our surgeons to unnecessarily take that blame, right? So this is bad disease biology. They progressed while on neoadjuvant therapy, and I'm glad we did not put them to surgery at any point in time. So these are again numbers that you have to keep in mind. So what did we learn from this very well-conducted study? Better R0 resections, improved disease-free survival and overall survival in a subgroup, which is the borderline group, not in the group that could be operated up front. Now, the question that we didn't answer properly is whether radiotherapy had any role at all. And this was nicely looked at a study that was read out in ASCO this year. A little complicated, don't run through these numbers. I will take you through this table. The study had 4 arms: surgery straight, gemcitabine, capecitabine followed by surgery, FOLFIRINOX followed by surgery, chemoradiotherapy followed by surgery, right? Exactly the questions that we are asking and hopefully the answers that we want. Now remember, borderline resectable, as I said, please look at what patients went into this study. They were borderline resectable, not resectable. And again, the criteria has to be looked at. Most interesting that patients who started neoadjuvant obviously were 90-95%, but look at how many actually complete. The less intensive your treatment is, the more likelihood of completing. One of the complaints by the North American group is that they thought Europeans, where this was SPAC is always a European study, is that they didn't know how to deliver radiotherapy, and that's why 25% actually did not complete it. Now, the other important point is that this is progression or death before surgery, right? 12%. Now, one of the doubts that we start getting is when did they do the scan and when did they ultimately operate, right? So ideally, your scan should be within 4 weeks of surgery. That means you did a scan today, you should operate within 1 month. The other arms look at progression or death, nearly 30%, which is what we said earlier. Resected, of course, 60% of patients who straight went to surgery were resected. This is a little less than what we would expect. We would expect 75%. But what is important is that delivering treatment before surgery did not increase the chance of resection, right? Now, why is this number like this? Because if you start with 100 patients here, the reading here is that 40 of the 100 patients did not undergo resection, a straight, simple interpretation. But when you're doing neoadjuvant therapy, remember that all patients who do neoadjuvant therapy will not end up in the operating table. So this should not, why is it that they won't? Because some of them have progressed while on therapy, some of them were not fit, and so on and so forth. So this should not be interpreted from just this number. it should be interpreted as a number from where you started neoadjuvant therapy, not just before surgery, right? So that is important to keep in mind. The other interesting fact is that the R1 resections were not very different except in the arm that took radiotherapy. So there seems to be some benefit in terms of R1 resection for the addition of radiotherapy. Node positivity rate was again lower, which means that these treatments are effective. But what people are really, hopping about is this 1 year overall survival of 42% if you did surgery only, followed by, of course, adjuvant therapy, or the higher numbers that you're seeing again in these arms, but that's dropping in the radiotherapy arm there, right? So the carry home from this is that there is some merit to adding neoadjuvant therapy. More people complete. R0 resections seem to be a little better, though not as much as what we would expect it to be. The surgery arm only, this only surgery arm seems to be doing poorer in terms of overall survival. So this is a push to push all these treatments into the neoadjuvant setting rather than later. So there is, that's the direction we seem to be taking. Now, if you did this, which one should you do? Should you do modified FOLFIRINOX or gem nab paclitaxel? And to our surprise, the result was that whether you do FOLFIRINOX or whether you do gem nab paclitaxel, the results were not different. That was very surprising for most of us. Now, the numbers are not as what you got from the FOLFIRINOX study earlier, which is 54 months, because some of these are, not some of these, all of these are borderline operable, and this is what you would get in patients with borderline operable. This is not to say that FOLFIRINOX is an inferior regimen. So where do we really go from here? Have we answered the question clearly? For me, it is still not. So for me, I would say borderline operable merits some neoadjuvant therapy. So the questions that we are asking here is, should we do adjuvant or neoadjuvant? Again, if we decide to do adjuvant, then which chemotherapy should we be using? We try to answer that partly in the SWOG study, which we reviewed 5 minutes earlier. Is there a benefit of radiotherapy? I think we have not answered that because this is a small triad, not powered to answer that question. If we decide to do radiotherapy, the push seems to be towards SBRT and not CRT. When I say CRT, we are talking about conventional 5 weeks of radiotherapy. Everywhere where we are looking at neoadjuvant, the push seems to be towards shorter course of radiotherapy, longer rather than the long course of radiotherapy. Of course, you have to be careful if your tumor is very close to the bowel and so on and so forth. Selection of patient is very, very paramount. And total neoadjuvant therapy, again, is where we are heading towards. And many institutions, at least in North America, have already adopted this. That means you do chemo, short course radiotherapy, and then get on to surgery. That seems to be the direction that we are heading towards. Whether you believe it or not is left to the individual. So is there a benefit of neoadjuvant therapy in resectable? The answer, I would say, is probably not, but many people think that that's the way to go. Who should get neoadjuvant therapy? Borderline resectable. I have said the others, because we are talking about medically inoperable, those who have a high CA19-9 and so on and so forth. Should it be upfront chemo or chemoradiotherapy? At least based on the evidence, it's only chemotherapy, but I showed you some evidence that addition of radiotherapy might improve the margin negativity rates. Which regimen? We still don't have a high quality answer, but considering that FOLFIRINOX gives you better outcome in terms of responses, better outcome in terms of adjuvant therapy, I would say FOLFIRINOX would be better. Is it sequential chemo followed by chemoradiotherapy, or is it better than chemotherapy alone? At least based on the PREOPANC, it looks like the answer is yes. Who gets chemoradiotherapy after chemo if it's decided to do that before surgery? If you're responding or your imaging shows that it's stable disease, those are patients who should get chemoradiotherapy after chemotherapy. What percentage will undergo resection after neoadjuvant? That's between 70 and 80. There's some evidence to say that it might be as low as 60. So it depends upon how you calculate that number right from the beginning or after completion of neoadjuvant. Total duration of neoadjuvant therapy is 6 months, right? So that's the duration that you would want to do your neoadjuvant. If you did it as total neoadjuvant, if you're going to split it between neoadjuvant and adjuvant, then it's a total of 6 months. That's usually 4 months of chemotherapy and about 6 weeks of radiotherapy if you use that, or just 6 months of chemotherapy if that's what you're doing. I think we will stop there because it's 9:15. We won't do this part, locally advanced pancreatic cancer. We will take questions if there are any. So just to put that ultimately in perspective, we have slowly progressed, but steadily progressed. There have been increments in survival. We started with 16.5 months and said for all FOLFIRINOX, it's 54 months. That's a big jump, in my opinion, contributed by many things. Better supportive care, better patient selection, better surgery, better anesthesia, and some of the systemic therapies that followed. Remember that surgeons might get better, but surgery is unlikely or will not get any better compared to where you are. You can't go about resecting the whole abdomen and then say, I did better surgery. The push is towards lesser surgery. Is systemic therapy likely to get better? Because biological selection and systemic therapies, molecularly selected and targeted therapies, I think is the way forward, because that's what is likely to give you better outcomes. And this is specifically, I wouldn't say for surgeons because I really love my surgeons, but it's important that all of us understand this. In cancer surgery, biology is king. You need not necessarily be heroic all the time. Selection is queen. Technical maneuvers are the prince and the princesses. Occasionally, the prince or the princess tries to usurp the throne. That always happens. They almost always fail to overcome the powerful forces of the king and the queen, which is biology and selection, which is what is likely to get us better. Because if you want to choose based on biology, I think genomics is very, very important. And I'm very, very happy that all our surgeons, not only in our own hospital, but all over the country and all over the world, have realized this. And they're talking about all of these much more sometimes than many of us medical oncologists who are expected to talk. And I think that's a great success and the way forward. Thank you so much. And let's have questions if there are any. Nusrat, how do you take questions? Should I say stop?
What you said, no?
Yes.
Pancreas is one area where hypofractionation is not at all advised because it is close to duodenum and the chance of pancreatic necrosis are high.
That's correct. So that is why your selection. So Dr. Nagarjun Reddy, who is our very senior colleague, is making a comment that shorter fractionation or SBRT is typically not the best thing to do for pancreatic cancer because of bowel necrosis and so on. I very much agree that your patient selection should be good. Because if your patient selection is good and you deliver it to appropriate patients, the incidence of complications is no higher and the response rate seems to be the same as what you get with your prolonged fractionation. So again, we're coming to the queen, which is choosing your patients appropriately. Correct, Mr.
Right.
Ravi Jaiswal has asked, sir, Gem nab-paclitaxel worked in the metastatic and neoadjuvant setting, but it failed in the adjuvant. I never understood why. You never understood why? Okay, so the trial was not an appropriately conducted trial, Ravi. There were some subsets where it looked like Gem nab-paclitaxel would be of benefit, especially in patients who had negative margins, who had lymph nodes that were positive. But as I said, that is a subset analysis. The second lesson that we learn is that everything that's active need not necessarily work in the adjuvant setting because the biology of the disease might actually be different in the adjuvant setting. So I don't have a perfect answer to your question, but I think it's also to do with the trial process. Dr. Sarathi wants to know, what is your take on maintenance therapy in metastatic pancreatic cancer? There's no high-level evidence except for patients who have a BRCA that is positive, a germline BRCA that is positive, because olaparib in that situation has shown better outcomes in terms of progression-free survival. Now that's based on the POLO study. Otherwise, chemotherapy maintenance is typically not done. Now, having said that, in a disease that is bad in terms of the way it behaves, there are people who will do some form of maintenance therapy, but that's on a case-by-case basis because there isn't high-level evidence to support neoadjuvant chemotherapy, maintenance chemotherapy. You want me to go to my adjuvant chemo radiation slide? Where is that? Is that those are studies. So Nusrat is asking me about adjuvant chemo radiation. I think the problem is that radiation was not properly tested in patients with pancreatic cancer. It was usually tested in underpowered studies with a 2x2 model and so on and so forth, which never really answers. In fact, the available evidence is that there is detriment to the addition of radiotherapy. But I wouldn't really agree with that, and that's what this shows. So I think the problem is the kind of selection that they did in patients with the the GIT, the group study, and that's why it is not really taken as a positive study itself, right? So none of these studies properly answered that question. Now that is a retrospective subset analysis from the GIT, SG, whatever the group that you're talking about. So the problem is it is never been really looked at properly in the context of a clinical study. And I think that's why I'm saying that there might be a role in selective patients, but who is that? We really don't know how to define that group properly. Major vessels, locally, how to address that? So Sneha, if we say locally, it's local recurrence, that means I am assuming that it was initially operated and there is localized recurrence. So we wouldn't subject this patient to surgery. We would probably do systemic therapy and chemotherapy in a situation like that. So here's one place where systemic therapy and radiotherapy, I'm sorry. So here is one place probably where some addition of local therapy might add value because it's a localized recurrence. So that's the way I would look at it. Which therapy comes first? I would always do systemic therapy first because most of these failures are likely to be in the liver. So do systemic therapy, like say 3 months of that, hold that, look at what's happening to your local recurrence. If there is no evidence of metastasis still, then probably subject that patient to radiotherapy. So that's how I would look at it. Any influence on the type of chemo you choose? So the first question is, in most of these studies where intensive therapies were used, they had a very, very small sprinkling of patients over 70. So if you look at the prodigy, if I'm not mistaken, the percentage of patients who had more than 70, who were more than 70 years was less than 10%. So there were patients. We would decide based on how fit they are. That's, I think, the simple answer to that question. But age is very, very important. It might be better to do some kind of a geriatric assessment score in patients like that before you decide. That's one part of the story. The second issue that we always have to answer is that if you extrapolate from certain other subsites in the body, let's say, for example, colon cancer, based on retrospective evidence, again, there is evidence to say that oxaliplatin really doesn't benefit patients more than 70. Okay, so there is a possibility that some of these treatments don't really benefit elderly, and hence it might be improper to put them on a very intensive regimen. So I think it is a lot of judgment that ultimately goes through this. If somebody is fit and over 70, You really have to discuss this with your patient, talking about the inadequacies in terms of evidence that is there before you really decide. Just age probably should not be the way to decide on how intensively to treat. So if you've done Whipple surgery on somebody who's 75, then I would think that patient should be able to tolerate some form of adjuvant therapy also. And of course, if the recovery is not so great, some gentle therapy, if the recovery is great, we would certainly consider that patient for FOLFIRINOX also. Very good. Nusrat, you want to say concluding remarks? No.
Yes, conclude.
Okay, guys. So let's get back to work.